Greetings, everyone, and thank you for joining today's virtual roundtable, which we're hosting in honor of National Minority Health Month and its theme, Be the Source for Better Health, Improving Health Outcomes Through Our Cultures, Communities, and Connections. I am Rosalind Holliday Moore, and I serve as the Deputy Director for Programs for the Office of Minority Health at the U.S. Department of Health and Human Services. I will serve as today's moderator. The purpose of today's convening is to discuss ways in which the conditions of the environments where people are born, live, work, play, where we worship, and move through the life course, often known as social determinants of health, affect a wide range of health, functioning, and quality of life outcomes and risks. We will also explore innovative efforts and interventions to address and better understand the health disparities in racial and ethnic minority and American Indian and Alaska Native populations caused by these social determinants of health. You are encouraged to use the chat feature throughout this session to share comments and questions for discussion after the formal presentations. Next slide. I am pleased to be joined today by three leaders from the U.S. Department of Health and Human Services. Rear Admiral Felicia Collins, Deputy Assistant Secretary for Minority Health and the Director of the HHS Office of Minority Health. Dr. Monica Webb Hooper, Deputy Director of the National Institutes on Minority Health and Health Disparities at the National Institutes of Health, and Dr. Aditi Mallick, Acting Director of the Centers for Medicare and Medicaid Services, Office of Minority Health. Thank you all for joining us. I look forward to today's discussion. We will move seamlessly across the speakers to make the best use of our time. Our first presenter today will be Rear Admiral Felicia Collins. Thank you.
Hello, everyone. And again, my name is Rear Admiral Felicia Collins, and I have the true honor of serving as the Deputy Assistant Secretary for Minority Health within the U.S. Department of Health and Human Services and the Director of the Office of Minority Health within the Office of the Secretary. In brief, I describe myself as a pediatrician by training and a public health practitioner at heart. And for today's virtual roundtable, I will be providing an overview of social determinants of health to provide a framework for the subsequent comments of my colleagues. Next slide, please. Now, for those who may not be familiar with the Office of Minority Health, our mission is to improve the health of racial and ethnic minority and American Indian and Alaska Native populations through the development of health policies and programs that help to eliminate health disparities. Now, we don't provide direct clinical or direct social services. Instead, you can think of us as a research and development shop for policy and program development. And we use our functions related to analyzing data, convening partners, disseminating information, conducting policy and program demonstration grants. We use all of those functions to assess the impact of policies, programs, and practices on health disparities for racial and ethnic minority and American Indian and Alaska Native populations. Now, once we identify those successful policies, programs, and practices, we work to identify other HHS offices or even other partners that can support longer-term sustainability and spread. Next slide. Now, the Office of Minority Health has the pleasure of leading health observances for several racial and ethnic minority groups. And as was already been noted, we are gathered here today in recognition of National Minority Health Month. The theme for National Minority Health Month, as you've heard, is Be the Source for Better Health, Improving Health Outcomes Through Our Cultures, Communities, and Connections. And I want to note that this is the theme not just for National Minority Health Month, but for the subsequent observances led by OMH for the remainder of the calendar year. The theme focuses on understanding how our unique environments, cultures, histories, and circumstances, otherwise known as social determinants of health, of racial, ethnic, and tribal populations impact our overall health. Now, while the month of April is almost over, I encourage you to please learn more about National Minority Health Month and the subsequent 2024 health observances by visiting minorityhealth.hhs.gov. And there you will find graphics and social media messaging, reading lists for social determinants of health and culturally and linguistically appropriate services, partner resources, and more. Next slide, please. Now, people use the term social determinants of health and health equity a lot these days, but I don't think we do a good job of connecting the dots between the terms. So indulge me, if you will, as I remind you of some definitions and, more importantly, remind you how the terms connect to one another in the next several slides. So our colleagues at the Centers for Disease Control and Prevention have defined health equity as the state in which everyone has a fair and just opportunity to obtain their highest level of health. So this definition of health equity is grounded in concepts of fairness and opportunity for all, and not having mediocre health or barely making it health, but striving for the highest level of health. Next slide. Now, for those who are more visually inclined, this is equity visualized. And the first image depicts equality. So everyone's given the same support with the assumption that everyone will be able to see the baseball game when given the same level of support, which is not the case. The middle image depicts equity, in which individuals are given different supports to make it possible for them to have equal access to the baseball game. And the last image, which I especially like, also depicts equity, but in this case, everyone has equal access to the baseball game without needing supports or accommodations, because the barrier in the fencing, or the systemic barrier, has been removed. And isn't that what we're trying to achieve? We ultimately want to remove those systemic barriers that are preventing opportunities for us all obtaining the highest level of health. So when fairness for accessing opportunities is lacking, health inequities will exist. Next slide. And one of the ways we know that health inequities exist is when we see differences in health outcomes among different populations, or health disparities. Now, health disparity is defined as a population, or it describes a population that has a level of a disease or health condition that is disproportionate to the representation in the overall population. And so, for example, this slide provides a visual representation of a health disparity in the area of HIV, because it displays that African Americans make up 13% of the US population, but they represent over 40% of the new HIV cases. So the terms are interconnected, which I think is really important. Health equity is our goal. The presence of health disparities is a sign of health inequities. Next slide. And health inequities are driven by social determinants of health. The Healthy People 2030 initiative defines social determinants of health as the conditions in the environment in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. The Healthy People 2030 initiative actually drills down further to identify 5 key areas or domains for social determinants of health. And they include economic stability, education, access, and quality, healthcare, access and quality, neighborhood and built environment, and social and community context. Next slide, please. And inequities related to social determinants of health are not just theoretical. We actually have data in many cases that are produced by various agencies within the Department of Health and Human Services. And this slide depicts an example of economic stability disparities related to poverty. That is, racial and ethnic minority populations that have a level of poverty that is disproportionate to their representation in the overall US population. We also, unfortunately, see racial and ethnic disparities in other social determinants of health domains. For example, in education access and quality, there are disparities in graduating from high school within 4 years of entering 9th grade. in healthcare access and quality, there are disparities in receiving preventive healthcare. And in social and community contexts, there are disparities in adults that talk with friends and family about their health. And we know that this social connection of talking with friends and family is associated with improved health outcomes. Next slide. We also have visual models of social determinants of health. This diagram includes 3 segments depicting different points at which there are opportunities to address health. And at the top of the slide, or the upstream segment, that's where you find the underlying social determinants of health, those underlying social and economic conditions that create differences in health. Interventions related to this segment apply to the community level and attempt to address the root causes of socioeconomic and health inequities, such as poverty, employment, and education. However, we as a nation invest heavily in that downstream segment of healthcare. But improving health outcomes really requires that we invest our time, our energy, our resources in addressing those upstream social determinants of health. Next slide. The Department of Health and Human Services have established some goals to address social determinants of health that align with that upstream segment of the past panel, or the past model, I should say. Goal 1 is to build an interconnected data infrastructure. Goal 2 is to improve access to and affordability of equitably delivered healthcare services and support partnerships between healthcare and human service providers and with community-based partners. And goal 3 includes supporting public-private partnerships and leveraging community engagement. Now, I anticipate you will hear comments from my HHS colleagues that address one or more of these goals. Next slide, please. And when some question me about, whether do all these efforts within the Department of Health and Human Services to advance health equity and address social determinants of health, is all that really needed? I point to this example involving the Navajo Nation. So in June of 2020, the Navajo Nation had a rate of COVID-19 cases that was 2 times higher than that of other states with very high COVID case rates, including New York. But through a very intentional approach to address multiple social determinants of health and partnerships between the Navajo Nation, the Indian Health Service, the Centers for Disease Control and Prevention, and others, the new COVID cases dropped to 0 on the Navajo Nation at a time when new cases were being reported across the US. And while the COVID-19 pandemic was terrible and really horrific, in my opinion, it did provide us with an opportunity to put data, policies, programs, communication, and partnerships into action to literally save lives. So do public health actions addressing health equities, health inequities, and health disparities and social determinants of health really work? My answer is a resounding yes. Next slide. But we moved from those very hard-won successes addressing the COVID-19 pandemic to data that was released just about 6 months ago from the Centers for Disease Control and Prevention, depicting US life expectancy at birth for 2021 being the lowest it has been since 1996. All racial and ethnic populations experience a decline in life expectancy, including the white population. For me, the worst part of this scenario is that the decreases in life expectancy are mainly due to increased mortality related to COVID-19 and unintentional injuries, with the effect of unintentional injuries being greater than that of COVID-19 for multiple populations. Next slide. So while we've learned a lot from the COVID-19 pandemic, we have a lot of work to continue to do, my friends, and we can't take our foot off the gas. We have to keep moving that boulder of social determinants of health up the mountain. Next slide. One of the ways the Office of Minority Health is currently addressing social determinants of health is through a new grant initiative. And this initiative aims to demonstrate that community interventions addressing 2 social determinant of health domains can increase preventive health service utilization. The application period is still open and will remain open until May 15th. And so if you'd like to learn more information, you can go to grants.gov and the link on the slide will take you directly to the notice of funding opportunity. Next slide. In closing, I believe that we collectively have many, if not most, of the needed tools to make significant progress in addressing health inequities and social determinants of health. We have definitions, we have models, we have strategies, we have data, and we have a very compelling message that everyone should have the opportunity to obtain the highest level of health. The Department of Health and Human Services has and will continue to lead efforts across government and within states, territories, and tribes in this mission. But we can't do it alone. Partners like yourself are critical to include organizations and individuals engaged directly with communities. Each and every one of us have a role to play. And with that, I thank you for your time and attention, and I will pass the mic to my colleague, Dr. Monica Webb Hooper from the National Institutes of Minority Health and Health Disparities. Thank you.
Thank you so much, Rear Admiral Collins, for the kind introduction. I'm really delighted to be here participating, and I want to thank the meeting organizers for the invitation. Next slide. Next slide. So I'm here on behalf of the National Institute on Minority Health and Health Disparities, which is the youngest of the 24 institutes at NIH. Next slide. Here are the components of our mission, which include advancing the science of minority health and health disparities, training, communications, and collaborations across NIH and HHS more broadly. Next slide. So here are the topics that I will cover today, and I will make an additional point about social determinants, and then I'll provide a high-level overview of 3 NIMHD-supported resources that support the standardization and harmonization of social determinants of health and social needs data. Next slide. So a point about social determinants. Next slide. So this is the NIH SDOH definition, and the point I want to add is that social determinants of health are not negative per se, although it's commonly, this is how, it's commonly discussed in the literature, and they are also distinct from health disparities. So health disparities are preventable differences in the burden of disease, injury, violence, opportunities to achieve optimal health that are experienced by socially disadvantaged groups who often face discrimination. The similarity is that both the social determinants and health disparities are by definition modifiable, which means that they do not have to exist and they can be modified. Next slide. So stated another way, social determinants of health can be positive. They can be protective factors that operate to drive effective health promotion and well-being in advantaged groups such as clean air, water, great school systems, beautiful parks, appropriate social support, great healthcare systems, while they can drive health problems and undue burden, or what we know as health disparities, among disadvantaged groups. So I call the factors that drive health disparities the adverse social determinants of health. And the goal, of course, is for everyone to have positive and protective social determinants in their lives consistently. Next slide. So I want to talk about 3 resources. The first is HD Pulse. It is an NIMHD supported and developed resource, next slide, that is publicly available. It is, I think, of high utility for researchers, clinicians, community organizations, and really anyone who's concerned about health disparities. HD Pulse provides access to data that include social determinants of health data to identify disparities in some of the determinants, to help us formulate research questions, help us design studies that address the specific health needs of racial and ethnic minority communities. Next slide. So here's the homepage for HD Pulse. If you Google HD Pulse, it'll come up. On the left is where you access the data portal. And this is where you can identify, you can quantify and visualize a variety of health disparities. And then access to the interventions portal, which is still in development, Our goal here is to provide access to evidence-based minority health or health disparities reduction interventions. And we've been just delighted that the HHS Office of Minority Health is collaborating with NIMHD to support the build and the dissemination of these health equity promoting interventions that will be available to all in the interventions portal. Next slide. So HD Pulse generates data visualizations on, for example, the prevalence of health factors, as well as health disparities and their determinants. You can look at it at the national, the state, and the county level. And one specific reason to use HD Pulse is to help prioritize research and public health needs for specific communities. And these data are from national data sets such as the BIRTHIS, or the Behavioral Risk Factor Surveillance System, the Youth Risk Behavior Surveillance System, the American Community Survey, and Vital Statistics as some examples. Next slide. And HD Pulse users will have the capability to use interactive graphics and maps to identify differences by geography, exploring spatial, historical, and temporal trends that go over 20 years, to assess the magnitude of health disparities between groups, and also to examine some of the social determinants using a socio-ecological framework. Next slide. So here's an example of a figure that you can generate in HD Pulse. So these two lines compare deaths from diabetes complications over 20 years between American Indian and Alaska Native and white Americans. And you can see that there is a disparity over time that's been quite wide and also consistent. Next slide. Now, a recent addition and a feature of HD Pulse allows you to look at these data at the intersection, for example, of race, ethnicity, and in this case, urban or rural location. So this shows that the disparity that we were just looking at in diabetes-related mortality is greatest among American Indian and Alaska Native persons who live in rural counties. But we still see greater deaths in this community among persons who live in urban counties if you compare them with white persons who live in either an urban or a rural county. Next slide. And as a final HD Pulse example, you can also use this resource to compare rate changes over, this case, 5 years in a health outcome. Here we're still looking at diabetes mortality by race ethnicity. So compared with white persons who have a rise in this time frame of 2.7 in the rate, the Black persons in this data set have a rise of 4.3 in terms of diabetes mortality. Next slide. So I'm going to next tell you about another resource that's part of the Phoenix Toolkit. Next slide. So one of the important aspects of this is standard measurement, that the way we measure social determinants of health is the same way to the extent possible across all of our projects and studies for at least a few reasons, including these you see listed here and others. So healthcare systems, researchers are paying more attention, right, to how these social determinants of health, particularly adverse social determinants, affect health. So it's important that our screening practices are methodologically sound, are evidence-based, and are measured on the same scales, or scales at least that can be pooled or harmonized. And this will help us examine these data over time and by various characteristics. Next slide. So we say, the old adage is it's hard to improve what isn't being measured. And I think the new adage is it's hard to improve if we aren't all measuring the same thing. Next slide. So in support of this strategy, the Phoenix Toolkit is a web-based collection of standard measurement protocols. They call them protocols, it's instruments or measures that have been vetted by experts in the field through this really comprehensive consensus process. And this is the website. If you Google Phoenix Toolkit, it would come right up. Next slide. So NIMHD released a special collection within the Phoenix Toolkit focused on social determinants of health measures, and they can be accessed along that bottom row for on the main page of Phoenix. So the protocols that we have in this collection, are organized as a core collection and 2 specialty collections. And we hope that this encourages standardized data collection, the quality and consistency of the data collection to improve. We want to be able to facilitate sharing and combining data from multiple studies. Next slide. So these are the constructs that are available right now in the core collection that we encourage all human participants, projects, and studies to use. They include 16 basic measures, including demographics, which are not social determinants, but it's important that we measure them the same way, as well as social determinants such as access to healthcare services, food insecurity, health literacy, occupational prestige, and others that you see. Next slide. This table gives you a sampling of the specialty collections. So there are two of them. One are individual protocols and the other are structural protocols. And we can use these for more in-depth assessment. So beyond the core, if you're interested in specific social determinants of health constructs, the individual collection are measures where the information is self-reported, like questionnaires that are answered by the person or family or caregivers. And then on the structural specialty collection side, these are measurement and often data resources from publicly available data sets that you can download. And these are at the structural or things you want to look at the community level. So lots of social great information there that's relevant to social determinants. Next slide. So the next few slides are just to give you a sampling of what the web page looks like. So this is the web page when you go into the social determinants of health collection. This is what you would see. Background about the project if you were interested. Next slide. When you're in that core collection, the 16 measures that I showed you, if you're interested in a specific construct or measure, such as, access to health services, you would click on the link in the protocols column, and then you would be able to see the items on the measure and learn more about its development, which populations it was normed on, etc. Next slide. This is what you'll see on the specialty collections page. So same thing, you can click the link to access the protocol, or you can use that green box and it would allow you to add a measure. You can create your own set of measures and you can collect them that you can use in the future even. So you can add to your own toolkit. Next slide. Okay, so finally, the last resource I just want to mention is called SHARE. Next slide. SHARE is a very new NIMHD and NIH supported resource that I want you to be aware of and track and get involved in if you can. Next slide. SHARE stands for Science Collaborative for Health Disparities and Artificial Intelligence Bias Reduction. So this is moving us into more current technology that is important for us all to track because we know that this is the wave of the future and the future is now. Next slide. So SHARE is a cloud-based social science data platform. It offers researchers at all career levels and in multiple disciplines access to data sets that include social determinants of health and other social science data. It also has the ability to collaborate among investigators as they apply artificial intelligence, machine learning, and other advanced analytical techniques to these data who have access to work in a collaborative space in a secure setting, which is something that we also have to be mindful and careful with. Next slide. So SHARE has three overarching goals. The first one is to foster these research collaborations. Specifically, we're interested in increasing participation of women, of underrepresented populations within health disparities, data science specifically. We want to leverage the rapidly developing research opportunities that are afforded to us by big data and cloud computing. And third, we want to advance the efforts to reduce the bias that we know exists in AI algorithms by increasing the diversity of the experts and the people who have these skills. Next slide. So here are the components of SHARE, which are co-localized in the cloud. So first, users can access data sets, and these are relevant to SDOH, relevant to health disparities and health outcomes research. There's also going to be access to a data repository, which does comply with all the required data maintenance and sharing requirements. Importantly, the computational capabilities that SHARE provides are secure. We have access to collaborative workspaces for students, all career level researchers. And then, as I mentioned, it has the tools that we need to evaluate and mitigate biases that are associated with these data sets and AI algorithms specifically. Next slide. So when you're in the system, you'd be able to access, link, analyze, and export a wealth of data sets across various platforms to conduct research about health disparities, bias mitigation. They're listed here. We have Google Cloud, public data sets. The American Community Survey is an example of one of those. There are SHARE hosted public data sets. The behavioral risk factor surveillance system data is available, and that's an example of that. And then funded data sets on share. These are NIH grantee and intramural investigators data that comply with the data sharing policy that NIH has. For example, the Jackson Heart Study data would be accessible. Next slide. So remember that share is designed for everybody, new users, people with experience. NIMHD hosts a monthly think-a-thon series that I personally have joined and found very informative, covering a range of topics, providing actual exercises to put these tools and skills to use. The next one is May 15th at 2. And as the timing would have it, it's on health disparities and structural determinants of health. There is a QR code, next slide, that you can register. That same QR code is again here. And then on the right is just the QR code overall to be involved with share. So I know I said a lot in a short amount of time, but I thank you very much. And I'm happy to turn it over to Dr. Mallick.
Thank you, Dr. Hooper, and I will echo my thanks as well to our colleagues in HHS-OMH for inviting us to be here today, and thank you all for joining. I will take now the next 10 to 15 minutes to share a bit about current and emerging approaches to social drivers of health, specifically from a quality and payment lens, on behalf of the Centers for Medicare and Medicaid Services. And I'll make sure that we have plenty of time for Q&A. Next slide, please. So first I want to contextualize this, and I think Rear Admiral Collins did this at the outset, but just to bring us back to some of that context so that when I share specific CMS actions, you can see them through this framing. Last November, the White House led an all-of-government effort around the release of the U.S. playbook to address the social determinants of health. And it was really to highlight through these three main pillars the all-of-government approach to addressing and improving the social circumstances that surround individuals and communities and meaningfully impact their health. The first pillar is expanding data gathering and sharing, which I'll touch on in a little bit. The second pillar is supporting flexible funding to address social needs. I'll touch on that as well. And then last but not least is pillar 3 around supporting community backbone organizations, which we'll also get to. Next slide, please. Building on that foundation set by the White House for all federal agencies, the U.S. Department of Health and Human Services also issued a call to action called the HHS Call to Action, Addressing Health-Related Social Needs in Communities Across the Nation. This was led by our colleagues out of the Assistant Secretary for Planning and Evaluation. The motivation being there is ample evidence, as Rear Admiral Collins and others have shared, about the impact that social determinants of health have on variations in health outcomes. And we as a department felt like we needed to advance a set of policies and funding and training opportunities to really address those needs. So the purpose of this call to action document, which is linked at the bottom, and by the way, the White House playbook is linked on the prior slide if you're curious, also both Googleable, or use your search engine of choice, I should say. But really the purpose of the HHS call to action was to catalyze cross-sector partnerships. I know the folks on the phone represent not just healthcare, but maybe social care, community-based organizations, and other parts of the ecosystem that interact with individuals and communities. And so it's really designed to help facilitate enhanced coordination between healthcare, social care, and community-based settings. Next slide, please. Here are just some of the example actions that were called out in that HHS call to action. So for example, that community-based organizations would develop and or expand capacity to serve as community care hubs and or participate in a CBO network that's led by a hub organization. And I'll share a bit more on a subsequent slide about what I mean by community care hubs. Or that health systems or clinicians would engage community partners meaningfully through needs assessments and shared decision-making. That payers would consider covering and paying for certain allowable services. And the list goes on in terms of the role of public health departments, health information technology, and other stakeholders that, again, I encourage you to look up. Next slide, please. So with that with that framing, I'd love to now spend the next few slides on specific CMS actions across those pillars. So zooming back out to that first pillar of expanding data gathering and sharing. We at CMS oversee and regulate a number of quality and value-based payment programs across the healthcare system. And we have finalized a number of quality measures that tie directly to the ability to measure and address health-related social needs. And that's what's outlined on the slide here. So I'll draw your attention first to the top 2/3 of the slide around social drivers of health measures. These were finalized into the hospital IQR, or Inpatient Quality Reporting Program, for the fiscal year 2023 IPPS rule. IPPS stands for Inpatient Prospective Payment System. For calendar year 2023, those measures were voluntary. As of January 1st of this year, they are mandatory for all eligible facilities to report, and it will be linked to payment determination beginning in fiscal year 2026, which is, so the federal fiscal year starts on October 1st. So that's starting October 1st of 2025 is the start of federal fiscal year 2026. Those two measures are what's outlined on the top right-hand side of the slide. So the first is screening for social drivers of health, and that's the total number of patients, and this is scoped to adults, so 18 plus, total number of patients screened for social risk factors during an inpatient hospital stay or during an established care in the case of dialysis facilities. And now actually this has been expanded to other facilities as well on a different time horizon. The domains of screening include food insecurity, housing instability, transportation needs, utilities difficulties, and interpersonal safety. If that sounds like a familiar list, that is by design. So that is based on the domains that were used in the CMMI model, the CMS Innovation Center model for accountable health communities. The other part of that measure is the screen positive for social drivers of health. So the percentage of patients admitted or in established care in the case of dialysis facilities who were not only screened for all 5 of those domains, but who screened positive for one or more of the above domains. It is fully our intention to continue iterating on this measure such that it will include not just screening and screen positive rate, but will also include a measure of whether a closed loop referral happened and whether an individual was actually referred to and able to receive a service. The other measure I want to point out, again, in this theme of data gathering and sharing, is the hospital commitment to health equity measure. This is a structural measure that assesses a hospital's commitment to health equity using a suite of equity-focused organizational competencies. So participating facilities have to attest on 5 different domains, and those domains are what's outlined there in that last dot point. They have to attest to strategic planning, data collection, data analysis, quality improvement, and leadership engagement as commitments to health equity. And that's been mandatory since calendar year 2023, so last year. Next slide, please. Pillar 2 from the White House playbook is all about supporting flexible funding to address social needs. And these are CMS specific actions in line with that pillar. The first, and these are links that do work. So when you all do have the slides, these will take you to additional information about each of these. The first, the community health integration and principal illness navigation services. These are new codes and associated payment that were established with the 2024 physician fee schedule to allow for coding and reimbursement of services to help facilitate community health integration, which includes services furnished by community health workers when they're billing incident to a Medicare Part B provider, and principal illness navigation, so care navigation services for individuals with serious or chronic conditions. The next dot point here is a social determinants of health risk assessment add-on payment, So this is additionally payment to a provider or to a clinician that does a social determinants of health risk assessment as part of an annual wellness visit. We've also enacted a number of flexibilities related to telehealth for health and well-being coaching services, which is temporary, and for the social determinants of health risk assessment that I just mentioned, which is permanent. Shifting gears now away from Medicaid to Medicaid for a moment, there are a number of flexibilities in the Medicaid program that allows states to address health-related social needs of individual Medicaid enrollees. There are a number of states enumerated on this slide. It's actually a longer list than this now, but Arizona, Arkansas, California, Massachusetts, New Jersey, New York, Oregon, and Washington that have all received authority from CMS to use a mix of state and federal dollars to actually deliver services that address unmet health-related social needs. So that's things like an individual Medicaid enrollee who meets certain eligibility criteria can receive, for example, housing navigation services, or can receive medically tailored meals through the Medicaid program. There are other authorities in Medicaid for which some of those services can also be paid for. For example, the Medicaid managed care program through in lieu of services, and in some cases and in some states, housing and nutrition supports that are provided through home and community-based services authorities, which are, again, specific to Medicaid and will vary by state. And then returning again to Medicare, I want to make sure that folks know that in the Medicare Shared Savings Program, which is the longest running accountable care program that CMS runs, we've recently introduced the idea of advanced investment payments. And these are really upfront, $250,000 upfront for participants in the Medicare Shared Savings Program to build infrastructure and capacity to address social determinants of health, particularly in underserved and rural areas. Next slide, please. And this is my last slide before we have time for Q&A. Pillar 3 of the White House playbook is about supporting community backbone organizations. And this is quite a complex slide, so I won't go into it in grave detail, except to say that there is a community care hub idea or model wherein there is a hub or a backbone organization, and that hub is responsible for coordinating administrative functions, funding, and operational infrastructure that really enables, on the one side, healthcare contracting on behalf of a wider range of community-based organizations. So on the one hand, you have the healthcare contracting and billing piece. On the other side of the community care hub, you have all of the community-based organizations that can align and track outcomes and utilize that community care hub as a bit of an aggregator to perform all of those functions that you see there across the bottom. Everything from presentation to screening to connecting individuals to a social service or a medical service provider, to then number 4, actually providing that service, 5, being able to track the referral feedback, and 6, most importantly, being able to track associated health and well-being outcomes as a result of that service delivery. And that's less specifically in the CMS wheelhouse, but a core part of the work of some of our sister agencies within the Department of Health and Human Services. So wanted to mention it here, in particular our colleagues at the Administration for Community Living, or ACL. I realize that was quite a lot, so I will stop there and I will turn it back to Rosalind, and happy to take any questions. Thank you.
Well, thank you to all of the presenters. We will have them all available for our time for questions and answers. Quite a few questions in the chat, so we'll move through them as quickly as possible. And I'd also ask if any of the presenters have an opportunity to take a look and respond to any of them directly. Please don't hesitate to do so. That makes us get through the list a little bit faster. The first question that I'd like to pull helps reinforce the context. And it goes, what is the difference between social determinants of health and health-related special needs? And that question, Dr. Mallick, that might be for you.
Yeah, I'm happy to take that
jump
one.
in.
So, health-related social needs, just to clarify. So, and I can't remember whether it was Dr. Hooper or Rear Admiral Collins that said this, but social determinants of health exist for everyone. Social determinants of health are things like transportation, access to clean air, access to nutritious food. Health-related social need and social determinants of health, therefore, exist for an entire community. Health-related social needs are specific to an individual. So does Aditi have housing instability? Does Aditi have nutrition insecurity? And when we say unmet health-related social needs, what we mean by that is that an individual has a need that is going unmet, that is impacting their health. And the reason you'll see a lot of CMS terminology around HRSN or health-related social needs is because our programs are entitlement programs based on individual eligibility and individual enrollment, right? So an individual is eligible for Medicaid, and therefore the Medicaid program can address an individual's health-related social needs. We work closely with our colleagues across the department, and I particularly want to call out the Centers for Disease Control and Prevention, or the CDC, where many of their interventions instead are focused on a community level, which is not the purview of CMS. And so think of those terms as one applies more directly to a community while others apply more directly to an individual. But I will also admit that the terminology can get quite confusing.
Well, I think you were very clear in the distinction, and it leads to the next question. And I think Dr. Hooper, you might be able to respond to, which asks, what advice do you have for community-based organizations looking to gather social determinants of health and social needs data from the population that they serve?
Thank you. I appreciate that question. I think that the Phoenix Toolkit is a great place to start. And it's really the reason that we wanted to curate this collection of measures. Because I think there you would find many of the key demographic variables that you would want to assess in your community. And also you have access to many variations and constructs and data sets that are publicly available that would allow you to look at questions related to social determinants of health and individual social needs. So I think that that would be a great place to start.
Thank you for that. And if I could just hover there for a moment, there were a number of questions that were asking about the availability or the interest in behavioral health and mental health, and data that's looking at sexual orientation and gender identity. Wondering if you might have an answer there, Dr. Hooper, before we move into the next category. Yes, so certainly. In the SDOH collection that we've curated, we have standard vetted measures to assess on the individual level. SOGI questions, sexual orientation, gender identity questions are there in the core collection. And you would also be able to evaluate the source. Where did these questions come from? How were they normed? You'd be able to see that very well laid out there. And then within the Phoenix Toolkit overall, you know, it's actually been around for a while and it's been funded. NIMHD recently began to co-fund this effort, but NHGRI, which is the Genome Research Institute, actually started this toolkit. So within that, you'll also see that there are other collections that have been developed. There are collections for mental and behavioral health. There's collection for tobacco regulatory science. I forget all of the ones that you see on the website, but also if you go just to the Phoenix Toolkit, and there's a search bar right at the top of the screen. And if you search a construct that you're interested in, I'd like to measure mental health, you would see all of the assessments that come up that would allow you to screen. It's mostly screening, not actual diagnostic tools there for mental health, as far as I recall, but you would see the options that are listed there. And I think it's a really great resource. Thank you for sharing that. And let's move a little bit into the geographical definitions and how that aligns with social determinants of health. We have a question here that says, what challenges have been particular in addressing social determinants of health in rural areas? And that can be for any one of you.
Yeah, I'm happy to start, and then Dr. Hooper, please add on. I think in our experience, many of the social drivers of health or social determinants of health impact rural communities differently. It's almost like the same challenges that not exactly, but many of the challenges that you see in urban areas are exacerbated in rural areas in terms of things like available workforce on the clinical side, availability of community and social support services, further impacted by things like long driving distances or reliability of network connections. So I think that said, I think very often some of the best innovations related to those challenges come from people within those communities. We certainly saw that during the pandemic, and we're continuing to see that now.
That's great. And I agree with all of that. I think from a research perspective at NIMHD, one of the, as NIH designated populations with health disparities is underserved rural persons who live in rural geographic areas. And some of the key challenges and we actually have a funding opportunity that is available to study social determinants of health in rural populations, led by the National Institute on Nursing Research. And NIMHD is participating in that. So we're looking for people to send us innovative applications to identify and address some of the key challenges. And we know, limited access to healthcare services, as was mentioned, transportation barriers, rural economic hardship can be quite common, workforce shortages, environmental factors. Rural areas may face unique environmental challenges such as, exposures to agricultural chemicals, lack of clean water, air pollution from industrial activities. So these are environmental factors, and we have an environmental health disparities initiative that also is seeking to address these issues in both urban and rural settings.
I think also the question gets to the concept of intersectionality. And so populations are not just racial ethnic minorities. They are often racial ethnic minorities that may live in rural and urban areas, or may identify with a variety of other demographic factors. And so in doing this work, it's really important to be mindful of all of those things. And definitely, unfortunately, what we see, as Dr. Mallick said, often you see a layering effect. As you add certain other demographic factors, you see a layering of the, and I appreciate Dr. Hooper, layering of the negative impact, the negative social determinants of health impacts.
Well, Admiral Collins, I'm glad that you mentioned that part, because one of the participants noted that from the Office of Minority Health, it seems that you have a high level, a broader view of the social determinants of health just on the mission that you described. And so the question is, can you provide suggestions or directions for resources or places that others can learn more about the social determinants of health and at a higher level, not so much in the detailed arena?
So absolutely. I mean, there are lots of different organizations and models that address social determinants of health. I tend to use the framework from Healthy People 2030. And folks know that's a national initiative led by the Office of the Assistant Secretary for Health's Office of Disease Prevention and Health Promotion. And that initiative gives science-based 10-year national objectives for improving the health of all in America. And so when you go to Healthy People 2030, you can type in social determinants of health. It will show you the 5 domains that I displayed earlier in my presentation. You click on each of those domains. It gives you specific objectives with related data that can be stratified, oftentimes by a variety of population types. Oftentimes it's race, ethnicity. Sometimes you get SOGI data, sometimes you get rural urban data, so you can see the data stratified. You can see what the national target is. So if you are working in a state level or a community level, you can see, have a sense as to where you may be trying to move within your geographic region. It just provides a nice starting point if this is, or not just provides a nice starting point, but I particularly like the fact that you can benchmark against national data and see national level data as you are working through the various social determinants of health. The other thing that's helpful within the Healthy People 2030 model is that they have something called leading health indicators. A lot of times those leading health indicators often are related to social determinants of health, and those have been identified as areas in which we have the ability to modify those areas, and that they've been, through research and other mechanisms, have been documented to, if modified, would have a significant impact on health. So given that there are so many areas in which we see racial, ethnic, tribal health disparities, if you're looking for like, well, where do I even get started? Healthy People can be really good looking at the objectives related to the social determinants of health, or looking at the leading health indicators.
Thank you for that. And I think we have time for one more question with short answer, and we can use it as a round robin to wrap up this section. And so the question is, how can communities and individuals stay up to date on new flexible funding opportunities? I think that may be pointing to Dr. Mallick to start us off, but funding is always key to advancing the work. So I think everyone will be able to have something to share here.
Thank you, Rosalind. Okay, I'll give you a short answer and then a slightly longer answer. The short answer is sign up for our listserv, and I'll make sure that you have the information for that. We send out updates regularly. The longer answer is two different types of funding that I would call out. One is the traditional reimbursement that CMS gives for healthcare services, right? So that is an enrolled provider in a Medicare program or Medicaid or what have you, and then billing for a particular code or service, some of which I articulated earlier, and getting paid that way, sort of traditional healthcare billing. We do also, the second thing I would highlight though, is that we do also operate some grant programs, mostly with respect to democratizing access to otherwise restricted CMS data for the purposes of doing health disparities research. Some of those are active and open right now and accepting applications. So I would refer you to the CMS OMH website. We have the Minority Research, I'll say these quickly and then you can look them up. The Minority Research Grant Program, the Health Equity Data, and the Health Equity Data Access Program. But again, I'll summarize and say the short answer is sign up for the listserv. Thanks so much, everyone.
You're welcome. I'm guessing that short answer might work for everyone, but Dr. Hooper and Admiral Collins want to be fair to you as well.
I would say absolutely. There is a website. If I can get it in the chat quickly enough, I will, but it's public.govdelivery.com, and it allows you to sign up for various listservs for NIMHD and other NIH institutes and centers. So I would encourage you to do that.
Thank you so much. Admiral Collins?
And for us, it's minorityhealth.hhs.gov. We likewise have a listserv where we send out information about grant and other funding opportunities, not just for our office, but for a variety of offices across the Department of Health and Human Services. So minorityhealth.hhs.gov.
And so with that, I would like to again thank our speakers today for sharing their experience and insights with us. Thank you to everyone for joining this discussion and for your thoughtful questions and adding to this robust conversation about social determinants of health. Asian American, Native Hawaiian, and Pacific Islander Heritage Month begins tomorrow. And the Office of Minority Health will continue to use our Be the Source for Better Health theme to highlight the unique social determinants of health impacting these populations. I encourage you all to follow the Office of Minority Health on our social media channels and subscribe to our newsletters and announcements to learn more about these factors and find opportunities to advance health equity for all populations. Thank you all so very much and wish you a good rest of the day. Take care.